Whoa, oh, oh, here I am, on my knees again. I'll do anything just to make it right. Say you love me.
Hello and welcome to MoveWell. I'm your host, Adrian Miranda, and with me today I have Ivan Hernandez. Today the topic is ACL. I'm sure you know someone who has had an ACL surgery or is going to have an ACL surgery. If you haven't, then you've seen it on the news because some professional athletes have had their ACLs torn. Recently, a couple of years ago, Mariano Rivera has his torn. So we're going to go to a clip where a doctor talks about his injury.
Well, the ACL is a tragically vulnerable ligament, and ACL injuries are all too common. I mean, in the past week, we've had Derrick Rose go down with a ligament injury and Iman Shumpert go down with a ACL injury. So this injury happens all too often, and it happens in well-conditioned athletes and poorly conditioned athletes. Unfortunately, we don't have great prevention programs at this time to protect the ACL.
Okay, Ivan, so you heard the doctor say ACL injuries can't be prevented. Why does a doctor say that ACL's injuries can be prevented?
In some part, I agree with him. I don't think there exists a program that would be suitable for all people, for all athletes. I think that everyone has a unique movement profile, and based on that individualized movement profile, requires a very specific intervention and corrective strategies in order to avoid these catastrophic injuries, ACL being included.
What do you look for? What do you do specifically to help someone either maybe prevent an ACL or who has had an ACL surgery that you're scared that they might have another one or undo the surgery or maybe on the other leg have a surgery?
What the studies that I've come across have shown is that the most robust reason for injury, by and large, is previous injury. And there's something to be said about why is it that previous injury predisposes us to future. Oftentimes what happens after an injury and even after the resolution of tissue damage, after the resolution of pain, we tend to move differently, oftentimes in very subtle ways that aren't perceptible to the coach, to the parent, and the athlete, him or herself. And I think these subtleties lie in motor control. We sometimes lose the ability to fire our muscles or particular groups of muscles in a timely manner. And when that doesn't happen, when we don't fire our muscles in that timely manner, that's when we subject ourselves to undue stress and future injury.
So motor control is the change in timing of muscles?
I would define it as the ability to stabilize one region, so in essence creating some level of stiffness, some level of rigidity, while in other areas of the body there's movement occurring. So generally we're looking for our lumbar spine to be relatively stable, hence lumbar stabilization programs, while our hips hinge. Likewise, we look some degree of stability of our hips in order that our knees hinge. So there's this concept of regional interdependence and this joint by joint approach where when you're looking at motor control, one segment is being relatively rigid and stable, while the neighboring region is being relatively mobile. And we tend to lose one of those features after an injury, whether it's motor control or whether it's a mobility from scar tissue that's developed or inextensibility of soft tissue or capsular tissue that has led to joint tightness and decreased range of motion.
So if I had a 12-year-old, I don't have a 12-year-old daughter, but if I did have a 12-year-old daughter and I wanted to get some knowledge, what would you tell me to look for? What would you do for my daughter if you were seeing her? Or what would you tell me to do for my daughter?
I would speak to you the way a dentist would speak to you in terms of avoiding dental caries. I would say, come see me periodically throughout the year and almost certainly before the start of the season. What I was referring to earlier was movement, and movement is a combination of motor control, mobility, the synchronization of movement that oftentimes occurs below the level of the mind, below the cortical level. That being said, we need to analyze it as healthcare professionals with a focus on movement. We need to analyze these movement patterns and determine if a patient or an athlete is predisposed to injury. So certainly a preseason screen would be suitable, periodic checkups in terms of analyzing movement. And beyond that, avoiding year-round play of the same sport. I think there's a lot to be said when you play multiple sports, in that you develop translateral athleticism. You develop an ability to engage your body in different ways, in different planes of motion, and you avoid overuse injuries. Another thing that I would say is that these other activities that should be looked upon after a season is over, doesn't always have to be structured or monitored. There's a lot of value in terms of ACL prevention when you just go to the park and run around and jump, because in essence, those things are plyometric based. You're running, you're jumping, you're playing tag, you're playing football. And there's a lot of evidence pointing to the benefits of plyometrics in terms of avoiding musculoskeletal injuries. And simply playing in the park is plyometric in nature.
Okay. What about to look out for? Like I've seen, girls running or even some guys running too, and you see their knees coming in together, or if they jump, their knees kind of touch, and it just looks awkward. Is that something that parents should look out for, or is there something that's like a key that you see when you see that, or what's your thought process about that?
I generally tell my patients and my students, I tell them that the knee is, while a complicated joint. In school we learn that there are many accessory movements that occur. It's not just a bending and straightening type of joint. For the most part, it is a bending and straightening joint. It's a hinge joint. It's a modified hinge. Mm-hmm. And a lot of what happens at the knee is a result of what's happening below and above. And so the statement I generally will tell my patients is the foot and the ankle tell the knee what to do, and the knee does what the hip allows it to do. So in that regard, an assessment is always required in order to determine what's happening above and below. And they could be different things for different persons. You could have a restricted ankle, and it could cause more pronation, leading to this valgus stress that you described, this collapsing at the knee. So someone who presented with a restricted ankle would need specific modalities and manual therapies. It could be a mobile ankle, but a very sloppy foot, and someone with a sloppy foot may benefit from orthotic correction or barefoot activity in order to waken up these foot intrinsics. It could be someone with relatively weak abductors. There's been a lot of research pointing to the benefits of glute medius strengthening to prevent collapsing at the knee.
What are hip abductors and gluteus medius?
Hip abductors are, in kinesiology, we learn them as muscles that pull the thigh away from midline. But in applied anatomy, certainly in the sports arena, what these muscles do is they control the effects of gravity. They control ground reaction forces. So when we're walking, when we're running, when we're jumping, we're subject to the forces that are going up the kinetic chain. And the way we respond to that is by pronation. And now, a lot of people tend to think that pronation only occurs at the foot level. But pronation occurs throughout the kinetic chain. And our role as healthcare providers is to optimally slow down or decelerate those pronatory effects when we're landing and jumping.
Pronation is when the foot goes flat, correct?
When the foot goes flat, when the leg bone, the tibia internally rotates, when the thigh bone internally rotates, when the pelvis anteriorly tilts. And so all that being said, the glute medius and the hip abductors are designed to slow down the thigh bone, the femur, from internally rotating, which will directly affect what's happening at the knee. Which is why if you look at a lot of ACL programs, although I'm not a proponent of programs because I think everyone has an individualized movement profile, but when you do look at most ACL programs, they often involve the strengthening and the activity of the hip muscles, particularly the hip abductors.
Now we're going to move to cartilage tears and meniscus injuries. There's an article that came out on CBS News online, and it showed that in a study of the New England Journal of Medicine and the American Academy of Orthopedic Surgeons showed that physical therapy is just as good as surgery for treating meniscus tears. So my question to you, Ivan, is why do they continue, or why have they been doing meniscus surgeries where they shave out the cartilage in the knee and they take it out, or sometimes they repair it? Why have they been doing this for so long? And then currently, we found that there's no significant benefit to surgery versus a more conservative treatment. Why do they continue to do this? If the American Academy of Orthopedic Surgeons made this statement, what do you think?
It's been a long-held concept that structural damage is linearly related with pain and dysfunction. So if there's a great deal of tissue damage that's evidenced with imaging, MRI, X-ray, CAT scan, then it's that structural damage that is causing the dysfunction. We now know that that's not the case. There are many people with a great deal of structural damage that are asymptomatic, without symptoms. And the reverse is true, where there are people with very little structural damage but have a great deal of pain and dysfunction. I can't tell you how many times I've seen people with imaging studies that have looked horrific. You would wonder, how is this person walking, let alone running a marathon? I've seen the ugliest feet in the world, and yet these people are able to function at high levels, run marathons, and play soccer. The point is that structure and function are not linear related. And when you're considering surgery, particularly for meniscal tears, I think you want to consider that very same concept, where as long as you remain functional, despite what the pathoanatomical diagnosis is under imaging, I think it's always in the patient's best interest to consider conservative management first. There are certain there are certain components, there are certain considerations that would make you think otherwise. If it's a large meniscal tear and there's mechanical symptoms like a locking or blocking sensation, that's when you may want to reconsider conservative management versus surgery. But outside of those very obvious symptoms, small tears, as this report has shown, could be just as effective as, it could be effectively treated conservatively as it could be surgically.
Can you give us an example of someone that you treated successfully with a meniscus tear?
I actually have a patient, or I had a patient who was an avid skier. Apparently he took a fall while skiing and he underwent an MRI. MRI showed that he had a meniscal tear. He received the prescription for physical therapy as prehab, meaning that he was going to do some degree of physical therapy before scheduling the meniscal surgery, the meniscectomy. What ended up happening is that in the prehab, he did so well. All symptoms were resolved. Pain was resolved. He was able to return back to his pre-injured status, and as a result, he staved off surgery. What did I do? I appraised his individualized movement profile. He had particularly weak hip abductors, and his ankle was tight. And it's It's the concept of regional interdependence. If your ankle is tight, it's going to cause your knee to go into that valgus collapse. It's going to knock it inward. And so I did a lot of manual therapies to his ankle. And I did a great deal of strengthening of his hip abductors. I'm also, let me say, I don't want to oversimplify it and think that there's a panacea and that the glute medius is the way to get out of knee problems. If I had to create a blanket statement or generalized statement, I would say, for the most part, that you want the focus when it comes to the knees, and in fact, most of the body, but certainly the knees, that your emphasis should be posterior dominant and lateral dominant. So everything in the backside of your body, the things that you don't see, your hamstrings, your glute maximus, your glute medius, your glute minimus, those are all the muscles that are very protective. And that goes across the whole body, the shoulders, the low back, the hip, the knee, the foot, the ankle. And so most of the time, the emphasis when you're working on someone conservatively to stave off surgery is that posterior lateral chain dominant approach. Particularly that means doing hinging exercises, Romanian deadlifts. I'm a big fan of stiff leg deadlifts. Sometimes I do seated curls. I do a lot of bridging with band work around the knees. I'm a big proponent of squatting in a pain-free range. I like box squatting because it gets the hips going back and down. I almost always work my patients at least a third of the time in a barefoot manner so that there's increased activity of the foot intrinsics. There have been a lot of studies that have shown that barefoot activity, not necessarily running, but balance activities allow for this co-activation pattern to occur where the sensory input going into the foot, because the person is barefoot, triggers the onset of hip muscles at the same time. And this simultaneous activation, this co-contraction, is what leads to enhanced stability at the knee level. So I do a lot of barefoot balance activities and a lot of posterior and lateral chain dominant activities.
Now we're going to talk about knee replacement surgery. We're going to go to this clip from NBC Nightly News in regards to total knee replacement numbers.
The numbers for total knee replacements are up in both men and women, topping more than 645,000 cases a year. That's double the number of wrist, ankle, shoulder, and hip replacements combined.
My question is, why do you think there's such a high number of total joint replacements occurring now?
There are a number of reasons. If you look at the numbers, for one, we're living longer. But while we're living longer, we're also more of an obese nation now than we were decades ago. And we tend to sit more now than before, certainly due to the advances of technology. And when you couple those things together, it leads to physical breakdown. It leads to morbidities, knee arthritis being one of them. So I think that there's a reason. It's not simply a coincidence. I don't think we're devolving as a species in the past 20 or 30 years. I think it has a lot to do with our lifestyle, modern day lifestyle.
So you hear this a lot. I'm just getting old. I'm sure you see patients that say that all the time. Do you believe that? And is there a way to avoid this inevitableness of bone-on-bone arthritis and the inevitability of having knee replacement? What would you tell someone who is 20 to 30 years old that's starting to feel aches and pains and saying, I'm just getting old, and then kind of seeing them through the lifespan, and at the time of 67 years old, they're saying, I need a knee replacement, it's bone-on-bone, it's just age. What do you say to that?
It's interesting. As I'm getting older myself, I'd like to think that I'm aging differently, or I at least like to be in control of my aging process. I often tell people that there's a difference between chronological age and physiological age. And the distinction between the two is that if we keep ourselves in shape, if we stay lean, if we stay mobile, if we stay active, we could certainly avoid a lot of the ill effects that happen with age if we're simply to not be as active, to sit down to not exercise as much, and as a result gain a lot of weight.
You said be active, but as we just saw the clips and we're talking about sports, people who play sports and who are active and marathon runners still have wear and tear. So is there a way to be active and avoid the replacement? Because it sounds like you're saying be active, you'll avoid it, but we see that even professional athletes, recreational athletes still might end up with knee replacement. So what's kind of your take on that?
It's an interesting question. I think what it comes down to is what causes damage in the knee. And certainly when you think of football, you think of traumatic insults to the knee. But oftentimes that's not the case. Oftentimes it's cumulative micro stress, the little things. And I said weight, but there's a lot to be said about weight. For every pound that we are overweight, what's experienced at the knee is fourfold that amount. So if I'm 10 pounds overweight, that's 40 pounds of extra stress on my knee during my activities of daily living. So I think what we're certainly in control of, these modifiable factors, is really staying lean, keeping our posterior chain strong by exercising, by doing functional activities like hinging, strengthening exercises, and squatting exercises, and remaining mobile. I'm a big advocate of yoga, of stretching and foam rolling and doing those things on a daily basis. I think if we could prevent and have an influence on these modifiable factors, we could limit the cumulative stress that leads to the deterioration at the knee that oftentimes people will consider having surgery for. So I think it comes down to those things. And staying active doesn't mean having to play basketball or football or tennis. It means simply not sitting down, parking, in the parking lot far away from your destination, taking the stairs, going for a walk, doing yoga one day and then maybe another day doing Pilates or doing cycling. I'm a big proponent of cross training because you avoid overuse injuries too. So you stay active, but you avoid this cumulative micro stress that happens with one particular activity. So what's good for the youth athlete is good for the aging adult as well. Stay active by participating in a number of different activities. Go food shopping. Walk to the mall. Walk to the local corner store. It's these type of things that has changed over the years. I think a lot of it has to do with technology and fast food and cars, and you could order things. You don't have to walk to the local restaurant and pick it up yourself. Just little things like that I've noticed over the years. When I was young, for example, I would ride my bike everywhere. I wouldn't get a ride, so I was active in that regard. Now, my son, when he goes to basketball practice, we drive him. And then he comes back, and while I want him to remain active, his instincts are to go to his Kindle or the iPad. So we're living in a different society, a different time, and I think what's good for that youth athlete in terms of I think we should certainly appreciate these things. I love technology, but I think if we put a limit to them and remain active, I think we could avoid these things. Stay lean and stay mobile. If I had to make a blanket statement, that's how you avoid many musculoskeletal injuries. If you go down the list of risk factors, as to why people get injuries, I said earlier, previous injuries, number one, and a lot of that has to do with motor control. So periodically go to a physical therapist and get assessed. Look at how you're moving. And I also said that mobility is a component of movement. So remain mobile. How? Foam roll, do yoga, stretch daily. I'm a big advocate of stretching daily. Another risk factor, your BMI, your body mass index. Bigger people tend to get hurt more, tend to have more back pain and hip pain and knee pain and foot pain. So stay lean and avoid the same activity day in, day out, do different things. So stay lean, stay mobile, and do a variety of different things and avoid excessive sitting.
In 30 years, what does Ivan do? You're knowledgeable, you're a physical therapist, but you're knowledgeable about the body. What are you going to do, or what are you doing now, or what are you going to do in the future to prevent a meniscus problem, arthritis, and a total knee replacement? What is Ivan going to do?
Great question. Well, when it comes to musculoskeletal injury and knee injuries, there are two ways these mechanisms could occur. Traumatically, and there's not much I could do in terms of preventing trauma. If I go for a layup and someone undercuts me, there's not much I could do about that. God forbid I were to get into an accident, there's not much I could do about it. But in terms of cumulative micro stress, there's a lot that I could do with regard to these modifiable risk factors. So my goals are to stay lean, stay strong, stay mobile, and when I do these physical activities, I do play softball, I enjoy that, I play basketball.
Let's fast forward to you're 80 years old though.
Okay.
Okay, you're playing softball. You know, at that age, what are you going to do to make sure you stay physically healthy?
Well, I'm going to eat well. I'm going to try to avoid sitting a whole lot and maybe walking to the store, walking in the mall, staying active with my family, whether it's my children or my grandchildren, picking up a hobby that requires me to get out the house. But I answered your question earlier that way because a lot of the problems that we experience as older adults are the results of what we're doing at middle-aged adults. So if I prevent it now, I could certainly avoid problems later on. And so that's really how you manage it. Addressing these modifiable risk factors that are certainly within our control. One thing that I'd like to say is that for the most part, the lay public and a large part of the medical community tends to think of physical therapists as remediators. So if we got a knee injury, you come to a physical therapist and you fix the knee, and then the patient is off on their way to do something else. But I think that we're musculoskeletal experts, and that being said, I think that we should involve ourselves as much as we can within the realm of wellness. And that means that it lies incumbent upon us to talk to our patients about nutrition, about sleeping well, about remaining hydrated, about remaining mobile, and all these other things beyond treating that pathoanatomical region that the patient came in for. And looking at biomarkers on a regular basis. Are you moving well? So even if you don't have pain, come to see a physical therapist 2 to 3 times a year, the same way you would your dentist, the same way you would your general practitioner.
Ivan Hernandez, thank you for coming on my show. That's our show today. Hope you join us next time. I'm your host, Adrian Miranda, and now you know how to move well.
Yeah, this was your city. You did it all and more, broke every law except for one, babe. Attraction, are you ready? I know you feel it, pull you nearer till you feel